Professor René Adam is the president of the medical board of Paul Brousse Hospital, France, head of oncologic surgery in the unit of hepatobiliary cancer at the hospital. Since 1994, he has held the position of professor of faculty of medicine in Paris-Sud University. Professor René Adams' main field of activity and research are surgery of the liver, biliary tract, and the pancreas, and also liver transplantation. Prof. René Adam is currently treasurer of the French Association of Surgery. He is a board member of the French Association of HPB Surgery and Liver Transplant. He chairs European Liver Transplant Registry, the Liver Met Survey, and International Registry of Colorectal Liver Metastasis. He is on editorial boards of journals, many journals, including societies such as American Society of Clinical Oncology, European Society of Surgical Oncology, the ISOS, and the European Surgical Association, and IHPBA. Prof. René Adam has delivered over 600 lectures on his research interests around the world and has over 400 publications in peer-reviewed journals. He has a citation of over 27,000 with a H index of over 78. So without further ado, I would like to request Prof. René Adam to give his lecture and look forward to it.
So it's a real pleasure to be with you. I hope that everybody is hearing me because I have a problem to hear you. And anyway, I would like to thank the organizing committee to invite me to speak about the advances in the multidisciplinary management of colorectal liver metastasis. These are my disclosure. And I will begin by saying that metastatic colorectal cancer is a real problem of public health with almost 2 million new cases per year worldwide. Liver metastasis representing 50% of all the patients. And these represent the total number of deaths in the world, but liver metastasis account for 2/3 of these deaths. And these emphasize the importance to treat the colorectal liver metastasis. So I will try to show you a little bit the history of the evolution of the idea. And the past history was that in 1994, this publication showed that comparing all the different treatments for colorectal liver metastasis, resection is the only one giving the possibility of long-term survival. But what we know is that only 10% of the patients are resectable, the majority of them being non-resectable. And only the resectable, of course, are going to surgery, while the non-resectable go to chemotherapy. But in the past, we had a very non-so-efficient chemotherapy with only 5-FU, and only 15 to 20% response rate, I would say 10 to 15 years ago. And so at that time, the patients who were treated by surgery were only 10% with a 30% 5-year survival. And the non-resectable patient have only 1-2% possibility of long-term survival. And these patients were treated by surgeon. These patients, non-resectable, were treated by medical oncologists. And these two worlds were ignoring each other. And so what has happened in the recent years is a fantastic change in the efficacy of chemotherapy. The first revolution has been the discovery of oxaliplatin and irinotecan, who doubled the median survival, tripled the response rate. The second revolution has been the discovery of targeted therapy, who has made that from only 1 year median survival, we have come to a 3-year median survival for all the patients, and a tumor response rate of around 80% of the patient versus only 15 to 20% in the year before. And now we are living probably the new revolution again, the third revolution, with the discovery of immunotherapy. And so chemotherapy has changed a lot, but surgery has also made a significant evolution. And to demonstrate the evolution, I would say the indication for surgery of metastasis in the year 1997 were very, very drastic selection of patients. Metachronos, unilobar, less than 3, less than 5 centimeter, more than 1 centimeter margin, a CEA of low value. But what we know is that if we accept this criteria, less than 10% of the patient will be eligible for surgery. And from such type of drastic selection of patient, we have come now to a more pragmatical rather than dogmatic selection of the patient. And today, everybody agree that we can consider liver metastasis resectable when all the liver metastasis could be completely removed while leaving at least 30% of remnant liver. And these even in the case with extrahepatic tumors, provided that these extrahepatic tumors are also resectable. And these, I would say, European criteria for resectability are also, I would say, joined by international criteria. Here you have the NCCN guidelines, but I'm convinced that in Asia, you have also the same type of criteria of resectability for the patient, for patient achieving a complete resection while leaving at least 30% of remnant liver. And to more clearly show the evolution of the idea, I would say I will insist on 3 points. The first point is the number of nodules. Some years ago, it was totally crazy to resect patients with more than 10 liver metastases. And a recent publication that we did on the Liver Met survey, which is an international registry on colorectal liver metastasis, show that when we resect completely even patients with more than 10 metastases, we provide them a 30% 5 years survival. And so today, the number of metastases should not be an absolute contraindication to surgery, provided that we could remove all the metastases. Another example is the type of resection. And usually it's common to say that it's much better to do R0 resection, the tumor and the margin of resection. But sometimes it's not possible. And we were able to demonstrate some years ago that by doing even a R1 resection, the survival of the patient was very, very similar to that of patients with R0 resection, even if the recurrence was more frequent. And today we may say that R1 resection should not be an absolute contraindication to surgery, because by operating this patient, we provide a better survival than patient non-submitted to any surgery. And the third example of the evolution of the idea is elderly patient. As you can see here, even patients with more than 80 years old may have almost 30% 5-year survival. And so today, age per se should not be an absolute contraindication to surgery. And these 3 examples show the evolution of the idea in favor of extending the indication of surgery of colorectal liver metastasis. And so even if by the past, resectable represent 10 to 20% of the indication, by expanding the indication today, we have gained a 10% more patient coming to resectability. And in spite of this extension of indication, the overall survival after resection of colorectal liver metastasis is in the Liver Met survey, which is the international registry with a lot of patients, a lot of center, a lot of country, and I'm sure that Singapore and Asian center are contributing to Liver Met survey. You can see that we have a 43% 5-year survival and a 25% 10-year survival, much better than patients who may not be able to be resected. And so we have changed chemotherapy, we have changed surgery, but the major change is the Oncosurge approach, meaning that we combine chemotherapy and surgery. And in the past, when we have such type of initially unresectable patient, and we had a significant downsizing by chemotherapy, usually we were continuing chemotherapy. But we have questioned, I would say, this attitude, and we have considered in the past a possibility of surgery. And by doing surgery, in fact, what we show is that with chemotherapy, we increase the survival as a short and medium term, but when we don't operate the patient, unfortunately, with a doublet or even triplet chemotherapy, we don't provide a significant advantage to the patient in terms of survival, whether the patient respond or did not respond to chemotherapy. And what we can say is that the targeted therapy has not changed this type of consideration, because even if we increase a little bit the survival, at long term, there is no possibility with anti-EGFR, in this case cetuximab, to increase the survival at long term. And what is true for anti-EGFR is also true for bevacizumab, anti-VEGF. As you can see here, the possibility for a patient treated by chemotherapy only to be alive at long term is very, very infrequent and very exceptional. And by contrast, when these patients initially non-resectable were submitted after downsizing chemotherapy to resection, we provide them a 33% 5-year survival, a survival which is lower than that of resectable patient, but higher than patients only treated by chemotherapy and not submitted to any surgery. And this figure is today shared by all the centers in the world. And as you can see here in LiverMed survey again, more than 4,000 patients initially non-resectable have been able to be resected with a downsizing chemotherapy with exactly the same survival rate than the original one that we published in our center. And so the objective of the strategy in colorectal liver metastasis is to try to increase resectability, because we know that it is the only way to provide a long-term survival. For obtaining this, what we know is that we should have a first-line, very efficient chemotherapy. Why? Because what we know is that when we correlate the response rate to chemotherapy and the resection rate of patient, liver only in blue or unselected patient in red, there is a correlation. And the most effective is the chemotherapy, the best is the chance of surgery. And as you can see here, in liver only, when you have a 70% response rate, you may have 50% of patients who are coming to a further resectability. And by using all the drugs today, this MD Anderson publication was able to show that we increase the number of drugs, but we increase also the number of patients coming to resectability, confirming that with liver resection, we have much better result as compared to no liver resection, and that the median survival after resection is almost the threefold that of patients non-resected treated only by chemotherapy. And so I used to say that the Berlin Wall between non-resectable patient treated only by medical oncologists and resectable one treated by surgeon, this Berlin Wall does not exist anymore, and that 15 to 30% of patients come from the non-resectability rate to the resectable one with a much higher survival benefit at long term. And so the consequence of this rescue surgery allowed by efficient chemotherapy is that 10% more patients are coming to the possibility of resection, and now 30 to 40% of patients with this mean. But what we have also is the possibility to increase resectability with optimized chemotherapy, because sometimes a first-line chemotherapy is insufficient to induce resectability. What to do? What we know is that the more line of chemotherapy we are conducting, lower is the response rate, and the lower is the progression-free survival. In addition, medical oncologists are considering surgery usually after a first line, but not so much after a second line or even after a third line chemotherapy. And this is not true. This is not adequate. Why? Because we have been able to show recently in a liver met survey study, including more than 6,000 patients, that when we consider patients operated after a first-line chemotherapy in green and a second-line chemotherapy in red, that the results are very, very similar. And even after the diagnosis or after the hepatectomy, the result being a little bit lower. But the message of this paper is that surgery should not be denied after the failure of a first-line chemotherapy if a second line or a third line is improving, I would say, the downsizing of the tumor. And when the systemic chemotherapy is not working at all, there is also a possibility for the medical oncologist to make an intra-arterial chemotherapy through the hepatic artery. And the experience of the Memorial Sloan Kettering Hospital in New York have very elegantly shown that we have a high rate of response and that we have also a significant benefit in survival at long term. This has been done in the US, but also in Europe, we have been conducting a prospective multicentric study showing that the triple infusion of oxaliplatin, irinotecan, and 5-FU into the hepatic artery, even in a chronomodulated way or in a conventional chemotherapy way, was able, with this triplet chemotherapy, in patients having a median of 10 metastases, escaping to first-line or second-line chemotherapy, we were able to show that the primary endpoint of the study, which was R0, R1 hepatectomy, was observed in 30% of the cases with a response rate of almost 41% in patients having escaped to first-line or second-line chemotherapy. So a possibility exists even in patients escaping systemic chemotherapy. Now, the medical oncologist could improve, I would say, the things, but the surgeon and the interventional radiologist could also increase the resectability in patients who continue to be non-resectable after a first-line chemotherapy. And as you know, when the remnant liver is too small, the possibility is to induce by a portal vein embolization an hypertrophy of the remnant liver, allowing the surgeon to do the resection in multiple unilobar disease. When the disease is multiple and bilobar and the less invaded liver contain up to 3 nodules, up to 3 centimeters, we can do hepatectomy combined with ablation. And this is, of course, the possibility. And for the patient who are the more, I would say, invaded by the tumor, and the remnant liver contain more than 3 nodules, more than 3 centimeters, at that time, it is impossible to combine hepatectomy with ablation. And at that time, the only way is to do a 2-stage hepatectomy or an accelerated 2-stage hepatectomy by ALPS. And this technique has been shown to be compatible with the long-term survival of patients. And still more recently, I would say the embolization of the portal system has been incremented by the embolization also of the hepatic vein. And by doing this combined embolization of the portal system and of the hepatic vein, is able to significantly increase the hypertrophy of the remnant liver and to try to achieve a sort of radiologic ALPS, avoiding the patient to operation and allowing the patient to be operated after such type of procedure. And so the consequence of the use of targeted therapy, of the use of this specific technique to increase resectability, gain 10% more resectability in the patient. And we come to the, I would say, a little bit provocative concept that a patient liver only, which is initially non-resectable, with the use of expanding indication, specific technique, rescue surgery, and targeted therapy, that 50% almost of this patient could come to a resectability possibility with, I would say, a significant increase in 5-year survival. Still, unresectable patient exists, unfortunately, even with the effort of the surgeon, the medical oncologist, the interventional radiologist. Is there a last chance? Yes, there is today a last chance, and with liver transplantation, and this is a case of a patient with a miliary disease, unfortunately unable to be proposed for, I would say, a curative hepatic resection. And today, we know that with liver transplantation, we can treat this patient. In the past, it has been done with bad result, and this was the 51st patient transplanted in Europe for colorectal metastasis, with only 18% 5-year survival. And because of this, and because of the fact that the transplantation is associated with 80% in benign disease, because of the shortage of organ, liver transplantation for colorectal liver metastasis was considered at that time as an absolute contraindication. But this was the past. 80% of these transplantations were performed before 1995, at a period where the management of liver transplantation was not so expert. We noted also that almost 50% of the deaths were unrelated to tumor recurrence. And because of this, I propose with the group of Oslo to try to do a much better selection of patients. And we were able in 2010 to publish the first preliminary experience of patients transplanted for colorectal liver metastasis in patients much better selected than in the past. And apparently the result seems to be better. And as you know, the group of Oslo was able in 2013 to publish the first series of patients transplanted for colorectal liver metastasis with a 60% 5-year survival. These prompt me to propose a randomized study, which has been begun 6 years ago, comparing liver transplantation with chemo to chemotherapy alone, with the objective to show at least a 50% survival after liver transplantation. And we have very recently finished this randomized study by including 96 patients. And I hope that we will observe the result within a period of 2 years, demonstrating or not that transplantation with chemo is able to give much better results than chemotherapy alone. But all these, I would say, need, of course, a multidisciplinary approach. It is evident that the medical oncologist needs a surgeon for resectability, timing of surgery, improve long-term survival. But it's also evident that the surgeon needs the medical oncologist for making unresectable patients resectable, to control the disease, to improve survival by neoadjuvant chemotherapy, and to try to prevent recurrence after surgery. But when I'm speaking about multidisciplinary management, it is around the table that medical oncologists and surgeons should take the good decision for patients. It's not just by phoning that we observe such type of consensus, because it's around the table very regularly that we may do the good treatment at the good timing for the patient. And the demonstration of the improved outcome of patients in the era of multidisciplinary team is given by this publication coming from an Asian group, showing that before MDT management, this was the survival of patient. And after MDT management, the survival was significantly increased, as was increased the incidence of liver resection in patient. However, multidisciplinary is not sufficient. We should increment this by expertise of the team. And by reviewing with a group of Liverpool patients who have been considered as non-resectable and who had liver-only disease, we were able to show that 2/3 of these patients could have been considered as potentially resectable if they have been reviewed by expert liver surgeon. And so in this patient, definitely considered as non-resectable by a general surgeon, there was a loss of chance to be resected because of the lack of expertise. And this is a publication in 2012, but more recently, the experience of the FIRE3 trial, who compare, I would say, two groups of medically oncologically treated patients, show that in fact, 53% of patients could have been retrospectively considered as resectable at the best response time, but finally see how many patients come to a secondary resection. Only 13%. So a gap of 40% patients who could have been resected have not been finally resected because of the loss of expertise. And these emphasize, I would say, the role of an expert hepatic surgeon in a multidisciplinary team decision for patients with colorectal liver metastasis. The multidisciplinary approach is further, I would say, stressed today by the importance of, I would say, the molecular biology. And as you know, KRAS mutation is associated with a worse overall survival in this meta-analysis of a lot of patients. And the question is, does molecular biology condition the prognosis? The response is clearly yes. And you have here an example, and this is a courtesy of Jean-Nicolas Vauté from the MD Anderson. Here you have a patient with a single lesion of the left lobe, and you may say this patient have a very good expected outcome. However, this patient was RAS mutant and died of disease after only 17 months. And at the opposite, you have this patient with a central, very big tumor, apparently with a bad prognosis. But see, this patient was RAS wild type, and he is alive with no recurrence after 16 months of the beginning of the treatment. And so this clearly demonstrates the importance of the molecular biology status of the patient, but KRAS alone is not sufficient to predict the prognosis. And we know today other mutations who are also very important to consider, and the higher is the number of mutations, the lower is the prognosis of the patient. And we know also that BRAF mutation is associated with a lower survival of patient and a lower, I would say, result after resection of colorectal liver metastasis. And so all these emphasize the need, of course, of the presence of molecular biologists also in the consideration of the treatment of the patient. Is there finally a possibility of cure? Clearly, yes, because as I say you before, the survival at 5 years is 43%, but at 10 years, all patients resected, a quarter of them, 26%, are alive at 10 years, meaning that this illustrates, I would say, the role of surgery. And this is also true even for patients with initially unresectable disease, for whom we have a 27% 10-year overall survival and a 15% 10-year disease-free survival. So even for non-resectable patients, there is a possibility of long-term survival. And the experience of the UK, United Kingdom, is clearly very, very important and demonstrative. Here you have the survival of more than 100,000 patients treated with colorectal cancer in the UK. Here you have all patients with stage 3, non-metastatic. Here you have the survival of patient metastatic, what we are dealing with, metastatic patient. But see what is the survival of patients stage 4 who have been resected, with a significant number of patients, more than 3,000. And you can see here the fantastic increase in survival of patients, emphasizing even amazingly that all stage 4 resected have even a better survival than patients with non-metastatic status. And so these demonstrate, I would say, the importance of, I would say, the surgery in this type of patient. I don't know, yes, okay. So surgery is important, but it is often not a one-shot procedure. And we know that we have a high recurrence rate. And when we have such type of recurrence rate, chemotherapy is important, but repeat hepatectomy is also important. And as demonstrated here in this paper, after the time of the last hepatectomy, we may have, I would say, almost the same survival benefit at long term after a second or even after a third hepatectomy. And this is clearly very, very important to consider, because when the patient continue to be resectable, we should, of course, try to do our best to resect the patient. Now, I would say the current base practice is clearly to try to increase resectability by extending the indication by the surgeon, by trying to convert initially unresectable patient to resectable one by the medical oncologist using chemotherapy in first or even second line, by using specific technique of increasing resectability by the interventional radiologist, all these with MDT management, but with expertise and the use of personalization through a molecular biology status of the patient. So I will conclude by saying resection up front of after chemo should be the objective in our tumor board meeting. We should use an optimal first-line chemo as short as needed to induce resectability, with an expert multidisciplinary team with well-defined criteria of resectability, with a fighting spirit from the oncologist, but also from the surgeon, even for locally advanced disease and in case of recurrence. And we should never give up in a way to give our patient the best possibility of long-term survival. And I will finish by saying that this was in the past two, I would say, non-communicating world that operated by surgeon, that patient managed by medical oncologist, and these two worlds were ignoring each other with a total indifference. And today, I would say the situation has totally changed. And from indifference between medical oncologists and surgeon, we have come almost to a sort of love story between the medical oncologist and surgeon, because they work together for the benefit of the patient. Of course, this is much easier when the medical oncologist resemble to this beautiful person and the surgeon resemble to this type of person. But I'm convinced that you have in your center beautiful medical oncologists and beautiful surgeons that could work together for the benefit of the patient. Many thanks for your attention.
So we will be taking your questions in the chat box. So Shrida will be able to read that. And if you have any questions here live, please come up to the mic and ask the questions to Prof. Adam. It's a great opportunity to ask Prof. Adam, who gave that lecture live just now. So do come up and ask your questions, and we'll be able to communicate with him.
So there are no open questions in the chat box at the moment. Maybe I will start off first.
Yep.
So with regards to aggressive surgery, giving us good results, versus transplant, how much marginal gain you should have to justify a liver transplant?
So this is a good question. What I will tell is that we should obtain probably in a near future the same result by liver transplantation that we observed for liver transplantation for benign disease. So in my view, I think liver transplantation will be acceptable when giving 60, even 70% 5-year survival in the patient, not to be in competition with benign disease. So 50% is probably not sufficient. I don't know if I have really responded to your question.
Along the same lines, actually, then I have the same a question along those lines. So bearing in mind that you're selecting for good biology patients, this trial, the TransMet trial that has just closed that you've told us about, is really important because obviously it answers this question of the advantage of palliative chemotherapy in good biology patients versus liver transplantation. I know the readout is in 2 years' time, but could you give us a kind of feel of what you see that survival advantage to be? Are we talking 20%, 30%, 40%? You know, like give us a taster of that, if possible.
Yes, no. Really, it's not because I close. It's not because I close. I must use the result. Really, my organization of statistic and research forbid me to have the result before all, I would say, the follow-up will be obtained. But what we have been able to make is to stratify the patient of TransMet by comparing them to the similar criteria observed by the group of Oslo. In the 2 publications that were done in 2013, the initial way of selecting the patient in Oslo, which was very close to what I proposed, and the one of 2020, which was still a more drastic selection of patients. And what I can say you is that we approach 5-year survival of 70, 80% at 5 years. I'm not speaking, of course, about DFS, because one of the Achilles heel of transplantation is the possibility of recurrence, especially of extrahepatic recurrence. But in terms of overall survival, we can observe with this selection in TransMet, as it was the case and reported by the Oslo group, overall survival rate at 5 years around 70, 80%.
Any questions in the chat? No. Yeah, you have another question?
Any questions from the floor?
Prof. Jimmy's got a question. Yep. Just hang on, Prof. Yep.
Yes, Professor Adams, excellent lectures. My interest is on peritoneal metastasis, and it's well known that for liver metastasis from colorectal or from any other primary cancer, that liver metastasis have much better biology, much better survival compared to lung metastasis or peritoneal metastasis. And what is the biological reason why liver metastasis is such an exception?
Did you get the question, Prof?
No, could you repeat?
Yes. So basically, we've seen and we know that the survival of liver metastases from colon cancer is good and therefore justifies all the resection as you've shown. Prof. Jimmy So is a professor of upper GI surgery here at NUH and pioneers a lot of work in peritoneal metastases and the surgery on the peritoneum. And his question really relates to, do you have a feel as to why liver metastases and that metastatic niche behaves so differently to that of the peritoneal metastatic niche in a patient with colorectal cancer?
It's a difficult question. I would say, for me, when we see the results of all the peritonectomy and so on, I think what has been demonstrated even in randomized recent study comparing the SHIP, the intraperitoneal hyperthermic with resection, is that in fact resection of the peritoneal disease give by itself very good result, and even almost similar to that of resection of colorectal liver metastasis. And so for me, the fight is almost the same between the peritoneal disease and the hepatic metastatic disease, in such a way that the best way, even in a period where chemotherapy is more and more efficient, but the best way to eradicate the tumoral process is to combine chemotherapy and surgery. Without surgery, I think, unfortunately, chemotherapy today is not sufficient. I don't know if I have really responded to the question.
You're getting lots of nods from the crowd. So then can I ask you a more philosophical question then? It looks like certainly in terms of operating on the liver and the two-stage operations, the ALPS, the rapids, and everything else that we do for colorectal liver metastasis and now transplantation has shown that technically almost any liver metastasis that's confined to the liver should be in the front of a tumor board, and in conjunction with surgeons and oncologists, a decision made about resectability. But given all the advances that you've also mentioned about immunotherapy, KRAS, BRAF, and all the other mutational analysis, just jumping forward, let's say 5 to 10 years, knowing what you know, do you think the day will come then that we would have signals by which we would say this is a bad signal, that actually even in resectable disease we need to back off and treat systemically, and there is a signal that's such a good signal that actually we could resect with, let's say, a vascular margin positive and R1 positive, but this is such good disease that we could throw everything at this disease? Do you think that day is coming?
Yes, really, I really believe that in the near future, molecular biology will emerge as a very important select tool for, I would say, determining the patient who should be treated by systemic chemotherapy, or patient that could have even surgery alone. Because up to now, we have been just working with the size of the tumor, the diameter of the tumor, sometimes tumor markers, but not so much. I really think that the clinical practice of routine molecular biology status of the patient will fantastically improve our way of selection of the patient, and could determine if we should do neoadjuvant chemotherapy or not, could determine if surgery has an important role, could determine if postoperative chemotherapy is useful or not. All the questions we have still today and who are pending in the management of our patient.
Yes, another question for me, Jimmy So, and I like the concept of oncosurgery. That what's your recommendation on how long the chemotherapy should be given before you consider surgery? And after your conversion surgery, how long is your duration for the postoperative chemotherapy?
So the questions relating to duration of perioperative chemotherapy in the neoadjuvant and in the adjuvant setting, what kind of feel for durations of time in those two settings would you say?
So for this, I would say the response is relatively simple. In the preoperative setting, what we recommend is to review the cases every 2 months for all the patients. I mean, every 4 courses of chemotherapy, we should review the cases with medical oncologists, radiologists, and surgeons, determining if the patient has come to resectability or not. And if after only 4 courses of chemotherapy in a patient a little bit marginally non-resectable, sometimes it is sufficient to go to surgery. And by this way, we avoid over-treated patients that this over-treatment could have also, I would say, an impact on I would say, the toxicity of the chemotherapy and so on. So as soon as the resectability is obtained, we should go to resection. And we should not have any dogmatic view to say we should do 6 chemotherapy or 8 or 12. No, we should do the less chemotherapy, the number of cycles needed to induce resectability. And when this resectability is obtained, at that time we proceed to surgery. And for the post-operative, here really we have no clear, I would say, recommendation in the literature. What we used to do, it's at least, I would say, 3 months of adjuvant chemotherapy in such type of patient, initially unresectable, with probably a very high risk of recurrence. And what we do is 6 to 8 courses of post-operative chemotherapy, reviewing them every 3 months. And if there is no recurrence after 6 to 8 courses of post-operative chemotherapy, at that time we stop.
So we have one last question.
Yep. So in HIPEC has been shown to be useful for carcinomatosis due to colorectal metastasis if the PCI score is low. What is your view on combining liver resection with HIPEC in selected patients?
So the question's to do with the with HIPEC treatment, and it's to do with when the PCI score is low, HIPEC is deemed to be useful, but in the presence of liver metastases and a low PCI score with peritoneal mets, would you combine the peritonectomy with the HIPEC and liver resection? This is the question.
Yes. The response is yes. We are not, sorry, I cut. We are not so expert in the use of HIPEC with peritoneectomy. And so when we know by advance that the patient have a peritoneal disease, we try to refer the patient to a specialized center who combine the HIPEC, peritoneectomy, and liver resection. But the usual way of selection in my country are as follow. When the patient has less than 3 metastases with a peritoneal disease, at that time, he has a combined approach. But when the liver disease exceeds 3 metastases and more, at that time, the expert team who do peritoneectomy, HIPEC, and resection of liver metastasis are, I would say, reluctant to operate this type of patient. Now, when we as hepatic surgeon are faced with the discovery intraoperatively of a very limited disease, peritoneal disease, and that all this disease could be resected, we do the resection of the limited peritoneal disease, as well as the resection of the liver metastasis. And we have been able to show in a published work that we obtain an 18% 5-year survival, which is lower than the usual survival for liver-only disease, but we prefer to resect all in one time when it is resectable.
Great. That's wonderful, Prof. Well, we will let you go. Sorry about the technical glitches on our side. Not sure what happened, but it's been a fantastically fruitful session and a really fruitful day as well for us. It's about 30 degrees here. What's it like where you are?
Yeah, we have only 24.
24, that's not bad for France. So take care. Take care then, Prof. We'll let you go, and thank you for your time. And big warm applause from all of us here at Singapore, and thank you for joining us.
Thank you. It's a real pleasure for me to share all this time with you. And I'm really sorry not to have been able to hear you and for the technical problem, but I hope that the main message has been well shared between you and me. Thank you so much.